hypercortisolism. The symptoms and signs of Cushing's syndrome, or hypercortisolism, result directly from chronic exposure to excess glucocorticoid. By far the most common cause is prolonged use of glucocorticoid agents for the treatment of chronic inflammatory diseases. Chronic use of inhaled corticosteroids or corticosteroid creams must also be considered as well. Other possible causes include pituitary adenomas, also known as Cushing's disease, adrenal adenomas or carcinomas, and ectopic production of corticotropin-releasing hormone, CRH, or corticotropin, ICTH. As with adrenal insufficiency, Cushing's syndrome may be elusive, and a high level of suspicion is needed. Symptoms can include worsening obesity, new-onset hypertension, skin changes, for example easy bruising, striae, poor wound healing, facial plethora, hirsutism, acne, muscle weakness and wasting, peripheral edema, and neuropsychiatric changes, for example depression, mania. Cushing's syndrome can be classified as ACTH-dependent or ACTH-independent. ICTH-dependent Cushing's syndrome is further classified as caused by pituitary adenoma, or by ectopic production of ACTH or corticotropin-releasing hormone. ICTH may be produced ectopically by malignancy, for example lung carcinoma, renal cell carcinoma, or by other tumors, such as carcinoid tumors in the lung, pancreas, or thymus. ICTH-independent Cushing's syndrome is caused by autonomous production of cortisol. Possible sources include iatrogenic causes, which is by far the most common cause, adrenal adenomas, adrenal carcinomas, primary pigmented nodular adrenal dysplasia, macronodular hyperplasia, and other, relatively rare disorders. Screening tests. The assessment of suspected hypercortisolism is difficult because cortisol levels fluctuate with the intermittent release of ACTH from the pituitary or from tumors outside the pituitary. Medications also affect cortisol levels, leading to false positive or false negative results. Establishing the diagnosis of Cushing's syndrome. The first step in evaluating Cushing's syndrome is to determine whether hypercortisolism is present. At least 2 first-line tests should be abnormal to establish the diagnosis of Cushing's syndrome. Late-night salivary cortisol, urinary cortisol, and the low-dose dexamethasone suppression tests are suggested as first-line tests. Urinary and salivary cortisol measurements should be obtained at least twice. The urinary cortisol excretion should be unequivocally increased at 3-fold above the upper limit of normal for the assay, or the diagnosis of Cushing's syndrome is uncertain and other tests should be performed. The diagnosis of Cushing's syndrome is confirmed when 2 tests are unequivocally abnormal. The patient should undergo additional evaluation if the test results are discordant or only slightly abnormal. If test results are normal, the patient does not have Cushing's syndrome unless it is extremely mild or cyclic. Establishing the cause of Cushing's syndrome. Plasma ACTH. The first step in the evaluation is to determine whether the hypercortisolism is ACTH-independent, or ACTH-dependent by measuring plasma ACTH. ICTH secretion is episodic in patients with Cushing's syndrome of any cause. Because of this, measurement on at least 2 separate days is recommended. Patients with an intermediate plasma ACTH concentration, 5 to 20 picogram per milliliter, should undergo CRH stimulation testing. The presence of an ACTH response indicates Cushing's disease. ICTH-independent Cushing's syndrome. A low plasma ACTH concentration of less than 5 picogram per milliliter in a hypercortisolemic patient is evidence of ACTH-independent disease. Thin section CT imaging of the adrenal glands is usually the next diagnostic procedure in these patients to look for an adrenal mass. If bilateral disease or a possible carcinoma is seen, additional testing may be indicated. Patients with ACTH-independent disease and bilateral adrenal micronodular or macronodular hyperplasia on imaging also require additional testing. ACTH-dependent Cushing's syndrome. In patients with ACTH-dependent disease in which ACTH is more than 20 picogram per milliliter, the final stage of the diagnostic evaluation is to determine the source of ACTH secretion. The great majority of these patients have a pituitary corticotroph adenoma rather than ectopic ACTH secretion, bearing in mind that ectopic CRH secretion is a rare cause too. These patients should undergo non-invasive tests, which is a high-dose dexamethasone suppression test and CRH stimulation test. Suppression of cortisol during dexamethasone administration coupled with increases in plasma ACTH and serum cortisol after CRH administration are consistent with the diagnosis of a pituitary adenoma. High-dose dexamethasone suppression tests. These tests take advantage of the fact that ACTH secretion by the pituitary adenomas that cause Cushing's disease is only relatively resistant to negative feedback regulation by glucocorticoids. In contrast, most non-pituitary tumors associated with the ectopic ACTH syndrome are completely resistant to feedback inhibition. Imaging studies. The diagnosis of Cushing's syndrome and its cause lie entirely in the domain of the endocrine laboratory. Imaging procedures provide no information about function and are useful only for tumor localization. Appropriate radiological and nuclear medicine studies should be used as directed by the biochemical studies. MRI of the pituitary, with and without gadolinium, is superior to CT scanning. Nonetheless, between 40% and 50% of pituitary tumors are missed by MRI in patients with Cushing's disease.
Audio Jungle. Audio Jungle.